You're listening to the RN Mentor, a podcast designed to document and bring you the work and experience of some of the most influential nurses in our profession. We will be sitting down and having a discussion with the leaders of today's nursing world as they share their work, how they navigate their nursing path, and their views on the future of the profession. My name is Ali Tayeb. I am a registered nurse, United States Navy veteran, a Jonas Veterans Healthcare Scholar, and your host for the RN Mentor. Welcome, everyone, to a new season of our Mentor podcast. I am very excited to be joined today by Sheena Howard. She is the founder of the Global Love-Led Leadership Movement, creator of the Love-Led Blueprint, primary care and mental health nurse, and professor at Fleming College. Sheena holds a Bachelor of Nursing Science from Queen's University School of Nursing and her Master's of Leadership specializing in health from Royal Roads University. Sheena's thesis, Inspiring Positive Change in the Healthcare System Through Love-Led Leadership, was awarded with distinction and won the coveted Founders Award. Sheena is a transformative nurse leader and coach and has coached, mentored nurses, physicians, healthcare professionals, and educators in this emerging leadership lens and consulted on the operationalization of love-led leadership in a variety of organizations. Sheena specializes in primary care and mental health of marginalized families and individuals, particularly trans-identified, genderqueer, LGBTQ2S+ people, and women, youth and children with ADHD and mental illness. Sheena was the first RN, second assessor for gender affirmation surgery in Ontario, Canada. She is the co-chair of the Registered Nurses Association of Ontario's best practice guidelines for the care of the LGBTQ community's expert development panel. Sheena has been invited to speak internationally on issues related to LGBTQ plus healthcare, nursing leadership, and primary care nursing. And I'm very excited to have you here with us, Miss Sheena Howard.
Thank you very much. It's really lovely to be here, Ali. Thanks for having me.
Thank you. So let's get started with this. So new season 2. Mm-hmm. Very excited to be starting with having you here. And just like with all my other guests, we're going to kick this off with how did you get started in nursing? What was the calling that brought you into the profession?
What was the calling? Well, before I do that, I just want to say I've been really looking forward to this because I have to admit, I thought that you only interviewed nurses with PhDs. So when you said I was on your list, I thought, whew.
My list does have a lot of doctoral prepared, and yes. No, I have to go around my circles, and people will actually answer my phone calls. So that's a lot of that is because who's answering my phone calls?
Well, I'm really thrilled to be here. So, I think the question was, what got me started on my journey into nursing? Was that the question?
Yes.
Yeah. So I have to admit, there's nobody in my family is a nurse at all. But what happened was in Ontario back in the 90s, we had to go to grade 13, and I had no idea what I wanted to be. And so my guidance counselor said, just go down to the library, because this was pre-internet, and said, go look at the information pamphlets in the library about, what you could do. Because it's my halfway through my first semester, we had to start applying to universities. And my mom refused to allow me to apply to be a police officer. Oh. Not that I wanted to hold a gun. I just thought helping people would be great. And so I picked up a pamphlet that asked the questions: do you like people? Do you like to travel? Do you like to help people? Are you always the first to offer care and consideration to your friends? There was a whole bunch of questions. And I checked yes, opened up the pamphlet, and it said, have you considered nursing?
Oh,
And it was like I don't know what happened, but this massive light bulb went off over my head, and I said, I want to be a nurse.
very
And
cool.
I know. And so then after that, it was just, I applied to university and got in to my first choice. And it was really, really difficult. Nursing school was incredibly intense. And I was so happy that when I was finished, it was also intense because my preferred, nursing lens, or my preferred specialty, was public health and primary care. And we were actively discouraged from going into those areas because they said, oh, you'll lose your skills, and oh, nobody's going to, want to hire you into acute care. We didn't train you for that. We trained you to do this and go into the hospital. And it was just my luck that I had ADHD. I have ADHD, and I went, oh, well, whatever. I'll figure it out. If I can't do it, I'll find a way. So I was able to structure my placements into primary care and public health, and then had a really amazing class that talked about Indigenous communities in Canada and nursing in Indigenous communities. And I that was where my heart's calling was. And so I graduated school and sold everything in my apartment, packed up my little car and drove across the country and moved out to Haida Gwaii. I took a job. Haida Gwaii is a set of islands just off the northwest coast of British Columbia, close to Alaska, to work and live in an Indigenous community there, doing public health and primary care. And it was, I'd have to say, to date, is still my most favorite job I've ever held. It was such a wonderful experience.
That's beautiful.
There.
That's beautiful. I mean, we've where I'm teaching right now. We just started in the last couple of years. We've had not a couple of, last year we've had an ambulatory care course where we've kind of it's an extra course. It's an elective that our students, a select number of our students can take. But it's just having that exposure of taking them out of their comfort zone of saying acute care, and it's such a different experience. And so many of the students come back and say, "Wow, it's such a different role, and it's such a it's still rewarding, but it's something they're not exposed to." I think we've overdone it with like acute care definitely has a place in our role, but primary care and especially working with the Indigenous community, I think that's the beautiful part for me. I mean. That's really
amazing. And it's important in nursing schools to have that kind of exposure. We're not all the same people, and in my way of thinking, while I would be really good in emergency care, because, I'm good in an emergency, it's not my style. It's not my love. It's not my passion. And so why would I want to go and work in there and be unhappy and burn out quick, right? Where I could work in a place where I was doing something that I loved and enjoyed, and would stay in the profession for a lot longer, and wouldn't get as dissatisfied. So I was really blessed to really love my job. And then I had kids, and apparently that changes your life. I got married and I got married and had a child. And so we decided to move back home to my hometown. And then that's when I got really immersed in primary care and mental health. And I know that you teach a leadership course, and one of the difficulties about being in primary care, similar to what Robin Cogan talked about in her interview with you, about there's no way to grow in primary care. There's no, because you generally report to the physician that you work with. And so in order for you to experience any leadership roles, you have to really think outside the box to be able to get, and experience or go into higher education to be able to access places where you could make a difference at a higher level.
Yeah, networking becomes really important, right?
Yes, really important, really important. And and I swore I'd never go back to school. Never, ever, ever in a million years would I ever go back to school. And then
I've made several of those promises or
Did you?
to myself.
Okay. Well, I'm glad it's not just me. But then I decided, I got thinking that if I wanted to go any further in my career, in rather than horizontally, but upwards, that I probably needed a master's degree. And so I elected to go and get my master's degree in leadership with a health specialization instead of nursing. Not that I was burned out of nursing. I just really wanted to do a deep dive into leadership. Mm-hmm.
Very
Yeah.
cool.
Yeah.
I'm really intrigued. So you are from Canada. You're
Yes.
practicing in Canada.
Mm-hmm.
So how does this the component of going into primary care work? Because I'm kind of intrigued about this because, like in the U.S., a lot of times, nurses think that this is the only place that they can go work in is inside of a hospital, and some people don't really have the passion for that. They would rather
Mm-hmm.
do something like ambulatory care. How does it work in Canada? Is
Um,
that
it,
the same issue or?
well, yes. Unfortunately, primary care in Ontario right now is the place that I'm most familiar with, but I do know that it does happen across the country in certain situations that primary care isn't seen as a specialty of nursing. It's seen as something that you go into when you're ready to retire because you work in a doctor's office, all you do is give needles, and support a few people with their diabetes, and that's about it. And so you kind of fall into it, or you fall in love with it, and then you make your way into it. So if a doctor has a position that opens up in their office practice, that is the way that you slide into primary care. Certainly, there's very few nursing schools in Ontario that offer primary care placements because it's seen as a place where you're not going to get to practice all your skills. However, as a full scope primary care nurse, I do all kinds of things. I do well baby visits. I run the vaccine program. I do psychotherapy with clients, smoking cessation, diabetes care, chronic disease management, case management, patient navigation, well women visits, including STD testing, PAPS, well male visits, all kinds of things. Whatever you're interested in, help parents or moms learn to breastfeed, support them in their breastfeeding, on like video conversations, video visits, telephone visits. There's lots of scope for nurses in primary care. So I don't know if that's the same in the United States. Does it sound similar or?
One of the things that I think we struggle with in the U.S. is really, and it's something that I'm seeing a little bit of change in, is having more actual RNs in primary care. A lot of physician offices default to medical assistants or licensed vocational nurses.
Mm-hmm.
So we are seeing a small change right now. I know there's a couple of organizations, especially in Southern California, that are expanding the hiring RNs in primary care. A lot of times it's sort of a back office, like they do like phone triage, they do back office work, and they do like management of the
Mm-hmm.
office, but not so much the one-on-one, like the stuff that you're doing right now, less of that.
Okay.
And hopefully we're looking at a shift to using registered nurses with those patients and doing the kind of work that you're doing. I mean, they can do it. They're just not utilized as much. And I think part of it has to do with cost, salaries, things like that, that
Yes.
nurses are a little bit more expensive to use. Yeah.
Mhm. Yes, yeah, and primary care nurses here in Ontario are definitely paid less than hospital nurses,
Oh,
which
wow.
is one of the things I've been advocating for is equitable pay for nurses in primary care. It's not unusual to see primary care nurses who've been working for quite a number of years actually getting less than a nurse who's just graduated who's starting to work in the hospital.
I have students that make more than I do, so
Oh,
I know
okay. So
how
you
that
feel
feels.
yes, yeah, yeah, and I think that sort of extends into the way that the profession, primary care nurse profession, has often been seen as a helpmeet to a physician, as
Right.
opposed to an independent practitioner who's regulated, who has a scope, who knows their business, who knows what they need to do. So, and is there for the patient as opposed to the physician. So, trying to change that that methodology, and that discourse has been one of the things that we've been working towards. It's
And I
getting
think
there.
I think the U.S. is suffering, and I think most of the world suffers from that that same concept that the nurse is working for the physician, and it is something I know we're working on the U.S. that it's a different scope of practice.
Mm-hmm.
Part of it has to do with, do physicians know the nursing scope of practice? And I think that's one thing that I think we've ran into quite a bit, is like the physicians have been, not I don't want to say to their fault, or that's their fault, but I think the way the culture of healthcare has been, and what the physicians are taught in school, how they're treated at facilities, it's
Yes.
been that thing of, the nurses work for you, and not
Mm.
they are an independent practice.
Team member.
That's a team member, right? They're
Yeah.
your colleagues. They are
Yes.
not there to take your orders and obey your orders and whatever else. And,
Mm-hmm.
so, yeah,
100%.
we can go off on this tangent for a while. So,
Yes.
yeah, I think it's something that we're also hoping, and it's one of the things that actually, even for our nurse practitioners in the U.S., half of the
Mm.
states in the U.S. Don't have our nurse practitioners do not have their full scope of practice, and they are attached to. They have to be attached to a physician, and like, for example, in California, they can't own their own clinic. They can only, like, I think they can only have 49% ownership of a healthcare facility. So
Okay.
it's things like that there's, new bills going everywhere. I think California is in the right path in becoming a state that has that's going to eventually have a full scope of practice.
Mm-hmm.
We're hoping that happens, but like I said, half the states in the U.S. do not. The nurse practitioners do not have full scope of practice.
That's
They have to
unfortunate.
be. Yeah, yeah.
And the exciting thing for RNs in Ontario is that the legislation has just been changed to allow for RN prescribing. So not even nurse practitioners have their own prescription capabilities, that they do their prescribing.
Right.
But then, so for example, somebody like me had taken an extra prescribing course, which would be really involved and in depth, would be able to prescribe basic medications for
Wow.
basic treatments for urticaria or otitis media or what have you, pink eye, that kind of thing.
That's amazing.
Yes. Yeah. And it really meeting the patients where they're at, because so much of what I do is that work with families and with people that need to be seen in not in an emergency room, but in our offices.
I'm
So
very envious of that. That's amazing. That's
yeah.
amazing. But it makes sense. It makes sense for some of the routine stuff that
Mhm.
you don't need to have a physician, and physicians do have their own specialty. There's a reason that they're there.
That's
So
right.
the fact that we spend so much energy and money on them seeing the common colds and flus and things like that, where a
Yes.
nurse would be just as capable of doing. But wow,
Yes.
that's great.
And in
Yeah.
some cases is the best choice for that
Yeah.
particular person. The one that, at least in the practice that I work in, each of the nurses have their own specialties, the people that they enjoy, not more confident, but that's just where they really enjoy being. That's their
That's where the
lane.
experience is, right?
And then the physician that I work with will say, you can see me, except you are going to get better care seeing one of my nurses who specializes
Wow.
in working with babies or working with youth. And I'll be involved in your care as the team, but this will be your contact person,
Wow.
which I think is a really good recognition and an important recognition of nurses' role and scope.
That's so much of a higher level thinking than I don't want to say than the U.S., but than the U.S.
Well, it's here in Canada too. There are I do get some looks when I say I'm a full scope primary care nurse, and they kind of look at me. And there are some physicians that still believe that nurses are hired because they hire you. You work for them to make them see more patients faster, as opposed to I'm hiring you for your skills in order to offer my patients this amazing skill
Yeah.
set. Yeah.
Did they study in the U.S.?
No. No.
We might have to take the blame for that. But
Okay.
yeah, that's amazing. That really is amazing. But having that awareness that there is other specialists that can do a better job. And I think it's more cost effective, right? It is a
Yes.
more cost effective
Mhm.
method when we talk about this. But in the U.S. we have a lot of lobbyists for the physician groups, and it's
Yes.
very insurance and reimbursement based, and um,
Right.
and um, you guys work on a different system, so I think that has a lot to do with it.
Yes, I think so. I think so too. And there's still some fee for service docs
Right.
around for sure. But when you look at what we've been able to do inside our practice by maximizing the scope of the nurses in the primary care practice, we've been able to reduce our CTAS 4 and 5 visits to the emergency room for our patient set. So that
Wow.
your colds, your all the like small things, we've been able to reduce that, but also reduce our hospital readmission rates,
Wow.
which is fantastic. And in terms of cost savings, it's if you multiplied that by all of the, there's over, I can't remember, 5,000 primary care nurses in Ontario now. I'm not 100% sure of the number, but if you were able to multiply that and apply those principles to every practice, you would see
Right.
such a reduction. And then we could redistribute some of those funds into places that are better, that need the help, like mental health and
Right.
children's health and that kind of stuff.
And if you think about it, even if it was one patient per one of those nurses,
Right?
that reduced the readmission, just the readmission rate. If you just took that
Yes.
one item,
Mm-hmm.
the cost savings would be enormous. So,
Oh, yes.
wow, that's amazing. Wow,
Yeah.
very very impressed. I might be moving to Canada after all.
You're welcome. I'm sure Trent University in Peterborough would love to have you in their nursing
Thank you,
program.
thank you, thank you. Uh, So this is fantastic. So I want to definitely want to touch on some of the other. You're doing so much, and it's amazing. I definitely want to touch on how did you get? So you are the founder for this global love-led leadership movement,
Yes.
and I love your website, by the way. Very colorful and happy website,
Thank
very
you.
informative.
Thank you.
So how did this come about? If you can just tell us a little bit about what it is about altogether.
Sure, sure. So, um, hmm, which part to start with first? Okay, I'll tell you how it came about. So I did my master's degree in leadership, and prior to that, just before I got accepted, I was terminated without cause from a position, from a job. And that was incredibly devastating to me. Although I can't talk too much about it, what I can say is that there wasn't any problem with my clinical skills or anything. I'm not 100% sure why I was terminated, but I was. And when I went into my leadership program, we had to really examine ourselves as leaders and then our impacts on engaging other people, how we engaged in system transformation. And I had to take a really hard look at how I led and what my leadership style was. And what I came to was that I had spent the great deal of my life as somebody who's lived with ADHD and anxiety, and also been an out lesbian woman. There's lots of places where you're told you can't do things, or you're told that you're too different. And also I've been accused of being really happy and optimistic and friendly and caring and kind and all these things. And of course, I accept the blame for all of that because I am. But what you end up learning is that you're different and unusual, and you need to do it in a different way. And so you can either internalize that and think that you're bad, or you can externalize it and think that they're bad. There's something else wrong with them. And so what I learned was a really healthy dose of how to put this, just don't ask for permission, ask for forgiveness later. And I also learned that to advocate rather than stay in inquiry. So for any length of time, I would just push back instead of taking the time to listen. And really, that's where my heart's home is. And we had to come up with our own personal leadership lens for one of our research classes. And I was looking at all of the different leadership lenses. So servant leadership, values-based leadership, distributive leadership, on and on and on, transformative leadership. And they all danced around this topic of love. that, they would even say things like, you have to love your people, or love is the source of power, and all this. But they stop short of saying that they lead from a place of love of humans, love of caring, any of that. And I just had this light bulb moment, and I thought, I'm a love-led leader. It just came to my head. And then what I chose to do was expand it and direct my thesis work in developing a definition and characteristics, and then afterwards a blueprint, a framework to be able to support people to actualize love-led leadership. So the definition that I utilized for my thesis, or that I researched and came up with, was that it's a philosophy in engaging in leadership practices that with based on the concern for others, to promote a strong affection between people, and that gives rise to others' well-being and the dedication and maintenance of their dignity. So pretty much nursing in a nutshell, I think, but also the kind of leadership that's needed now more than ever.
Right.
And when you look at the research around what leadership actions actually make a difference, the characteristics that I came up with, or that I could see that would be reflective of love-led leaders, are authenticity, passion, humility, accountability, and empathy. Did I say vulnerability? I think I did. Anyways, there's 6 of them. these characteristics that love-led leaders engage in order to practice it. So that's where it came from. And I wanted to share it. I felt like every time I explained it to people, there was a lot of light bulbs that went on. Like, right. Oh, that's me. Or, oh, I totally agree with you. Or, oh, I would never tell anybody that I did that. Because you don't say you love your patients.
So when I first looked at your website and it said the love-led leadership, do you have you gotten anyone that you've spoken to, or you've at a conference or anything you've done around the topic, that have been uncomfortable with the word love, using love in their leadership? I'm putting air quotes up for people because people can't see this, with the word love around it, because I think the word love makes people, or we've made people feel perhaps uncomfortable with that word and how we use it, just because I think we've sterilized so much of what we do. Just the word love is a word that maybe makes people uncomfortable, or perhaps they think it takes something away from them if they think the part of their description is love. So how did you ever get a feedback like that? Or
yeah, for sure. The feedback that I've gotten has been, that's really risky.
Yeah.
It's really risky to say. And I agree with them. I agree with them. We have these depersonalized, dehumanized policies and procedures that, not even just in healthcare, but in education, in businesses, that say that that take the humanity and the dignity and well-being out of our out of our practices. Right. And for a really small number of people, like, meaning that people that would go against that kind of belief, or people that wouldn't act as a love-led leader would, because love-led leadership isn't a license to abuse people or harm people. But to say that is a big risk. And so, yeah, people have said that. And I was asked in my defense, do you think you need to water down the term and call it compassionate leadership? And I said, no. I don't think so, because I think it's the time to name it. I think it's the time to call it what it is, and that many of us are working in this way where we come from this place of deep caring and wanting to maintain other people's dignity through all of our interactions. And that is the essence of agape love, which is sort of agape love is the Greek word for selfless love. Right? That you do it for the love of a human, love of humankind, as opposed to the romantic love, which is what we've come to know and understand.
And I think that's what's probably making people uncomfortable. They're not with the terminology, and it's with a lot of things that are going on right now. Like, I'm using a lot of words now in my courses that are making my students sometimes uncomfortable. And actually, I had a couple of students actually like talk to me later and said, they weren't sure how to react to it. Like, I've used words like recently with, around the Black Lives Movement matters that's happening with, I'm using the word racism and systemic racism and things like that in my my
Mm-hmm.
coursework now that I didn't necessarily use before. And I've just kind of pushed myself because I was like, should I use it? Should I not use it? And over the summer, I'm like, you know what? I'm using this verbiage because this
Yes.
is what we call it. And same thing with the word. And the reason I brought the question of, are people uncomfortable with that word is because in my head, I can just imagine one of the CEOs or nurse executives using that word. And I know I've had a nurse executive that I think was the perfect example of a love-led leadership, but I don't think that verbiage would ever be in her dialogue. Um,
Right, and the experience that I've seen executives, nurse executives, leaders, physicians have when they label themselves or they identify publicly with being a love led leader is just one of relief because there's finally a place where they can hang their hat.
yeah,
There's words that they can say that allows them to stay in their vocation and stay with their passion in their vocation, and it's just it aligns with how they were already thinking. They just never had the words to describe it, and those are the people that I'm targeting in order to be able to share it with them. Because I think once my experience was that once I was able to do that, I became a more effective leader and a more effective nurse. It kept me grounded and engaged. And when we choose, who else is going to use the words if we don't? Right?
right.
In our classrooms, as leaders in classrooms or leaders in our organizations. And the interesting piece about staying in inquiry longer than advocacy is that I've learned a lot about people who I generally would have othered, who would be sometimes some of the ones saying, why do we need to include LGBTQ people here? What do you mean we're not a safe place to go? What do you mean there's some, diversity and equity issues here, right? I would have love-led leadership has given me the opportunity to take a step back and look at what they value, imagine what they value, and then approach them from that lens. So it's
Yeah.
actually made my relationships or my abilities to engage in difficult relationships much better.
Yeah, that's amazing. I mean, being able to, and that's the piece I think I'm connecting the most to is that you're making it okay for people to use the verbiage, right?
Mm-hmm.
You're giving them ability to say this is the type of leader I am, and I think that's fantastic. And giving because like the definition that you gave and the values that fall under that are stuff that we
Mm-hmm.
use all the time.
Yes.
Is the language we're already speaking, but the
Yes.
overall arching to put it in one basket and naming that basket for them, I think is very valuable. So that's
Thank you.
amazing. That's
Thank
amazing.
you.
That's fantastic. Um,
And the blueprint that I've
yes, I was going to
developed,
ask about that.
it's the Be Love Led blueprint. So LOVELED, and so L is listen, O is observe, V is values, so like a values guess at what's going on for the person. E is express, so telling them what you've heard, what you've observed, and what you're guessing that their values are associated with that. And then listening, then repeating the process after you've expressed in order to hear what they have to say based on what you've said. And then led is learn, so learning back from them what they've told you. Explore, so explore possibilities, explore solutions, explore out of the box thinking, and then decide what's the direction we're going to go after we've created shared meaning and shared connection.
That's great. That's
So
great.
so you can use that when you're making decisions at the bedside, in the boardrooms in healthcare, in education, in classrooms, one-on-one in conversation, or in big group meetings.
Right.
I
Right.
found it really valuable as a tool.
Yeah,
Mm-hmm.
that's fantastic. And this is great. And actually, I have a lot of this information actually is on your website, and I want to
Yes.
make sure people listening to us right now, the links to your website are on my website, so we made
Mm-hmm.
that available.
Thank you.
And at the end of this, when we wrap this up, we'll talk about your website again. Make sure
Sure.
everybody has an opportunity to go on there and take a look. And you have
And the courses,
and
if
you
they
do
want to
have
take them.
courses, yes, and
Mm-hmm.
you do have courses that they can definitely engage in.
Mm-hmm.
Now, I want to little transition a little bit to some of the other
Sure.
work that you're doing with the LGBTQ plus community and policy work and things like that. Can you talk to a little bit about the work that you're doing in Ontario right now?
Sure. So right now, I'm the co-chair of an expert panel for the RNAO, Registered Nurses Association of Ontario, which is the nurse advocacy arm branch. I don't want to call it a branch, but organization that supports nurses, speaks out for nurses in healthcare, as opposed to our regulatory college, of course, which speaks up for patients, protects patients. And they are developing a best practice guideline for the care of the LGBTQ2S plus communities here in Ontario, although the BPGs from the RNAO have been used globally, so across the world in many different countries. And so the exciting part is that the opportunities for this BPG to be able to provide guidance to all healthcare professionals, not just nurses, about the community is phenomenal. So I'm really excited about that. It has the potential to change healthcare practices in primary care, but also into healthcare and mental health organizations. Done some advocacy work around ensuring that the government in Ontario funds gender affirmation surgeries for trans folks, for top surgery for trans men and bottom surgeries, which is really exciting, meaning that they don't have to pay for it anymore, which are up to and including, I think it was 3 or 4 years ago, maybe 5 now. Everybody had to pay. Some people had to go to the States. Some people had to go to Quebec in order to be able to have the surgeries. And it was hugely expensive, cost prohibitive, and also contributed to high suicide rates of the in the trans community.
Wow.
And also advocating for the care for trans folks and transitions to be grounded and housed in primary care, as opposed to going to have to see an endocrinologist, so that the access was available in the towns in which folks live and work. So here in our community, we in Peterborough, which is sort of like central Ontario-ish, we saw over 400 in our practice, over 400 trans folks from as far away as Southern Ontario, like Windsor area near the border of the States, all the way up into Northern Ontario.
Wow, that's amazing.
And so people travel from huge places. In order for that to be accessible, we supported and advocated for RNs to be second assessors in the gender affirmation application and assessment. So that was really exciting. So what that meant is it opened up even more access for folks to be able to have a really good assessment done, and then be able to have nurses be able to add their signature as qualified healthcare providers to be able to support their application for funds for the surgery.
That's fantastic. So now I'm curious about the RN role in this whole process, because I think that's so important, just because, again, with that accessibility and support system that puts into place. Now, does this so after surgery, do the RNs still have a role that they play other than routine checkups and things like that, or how does that work? How does that support system work?
So it depends on which community you live in. Some people have trans-specific clinics where folks can go post-surgery to be able to get support and continue to, if they're on hormones, that they can continue to be followed and monitored. Ideally, an RN scope would be to continue to do like post-surgical assessments, for infections and all of those things that you would do after any surgery. You'd keep your eye on that, but it requires not a lot of experience, but enough experience with culturally sensitive care of trans individuals to be able to support them post-surgery. So, in a nurse's role, being able to learn about culturally competent care of trans individuals, that's really important. But then afterwards, you've supported them through this life transition, and then they become a patient who simply needs primary care or simply needs to be engaged in the system, right? So that is making sure that their prescriptions are up to date, their blood work's up to date, all of those things. And then also being able to provide excellent preventative care, specifically for trans folks who have had gender affirming surgery. So what I mean by that is if we have a woman who has had gender affirming surgery and still has a prostate, then we need to be able to make sure that they're still getting those markers, those checks done.
Right.
Whatever body parts we have to make sure we're still checking for them.
Healthy. Right. Absolutely.
Yes. And oftentimes the RN is in that role of advocacy, making sure that those checks are still happening.
That's amazing. Because I think that's one of the things I think we struggle. I don't want to say we struggle, or I've observed. I'm going to say I've observed is we're not doing enough of the awareness in the community of taking care of trans folks, and we're not doing enough cultural sensitivity or that kind of education with our healthcare providers in general, not just nurses, but in general.
Yes. And I would agree.
Yeah. And I think that's amazing work that you've been able to do so much, and added this additional role for nurses to be able to step in and lead. I think that's
and if
amazing.
you think about the actual like the time between when a trans person identifies as trans and when they actually get support from the medical community, if it's a long period of time, they're at their highest risk of suicidality.
Right.
And you can make a huge difference in the life of somebody if you're able to open the doors really quickly.
Right. So thank you for sharing that piece, because I do primarily veterans research, and I think that's the biggest, and we do have a large suicide rate in the veteran community. And that transition period between a veteran coming out of the military and going into the civilian community, that transition period or reintegration is very difficult. And I think that's where we're seeing a lot of veteran suicide occur, is because that transition isn't necessarily facilitated or the support system doesn't exist. So as you're talking about this, that's what I'm in the back of my brain. I'm like, yeah, this is happening with other communities. But although it's not this type of transition for them. It is a transition, a life transition.
That's right.
It's a different culture. It's different. There's just so much change happening. If the support system doesn't exist, I think it becomes that much more problematic. And I think that's key. That's key.
I agree with you. And if the gatekeepers to care or the gatekeepers to support are saying, I don't know what to do with you. I don't know. I've never seen you whatever before, or I've never seen this problem or this issue. I don't know what to do. You got to go find somebody else. That is such a slap in the face, and in my opinion, such poor care.
Right. And actually, I'm again relating to this on a whole different level. I have PTSD from a military experience. Okay. So for me, I did go and seek, and I've never gone to our Veterans Affairs Health System because my PTSD is related to, I spent about a month doing a search and recovery for a commercial airliner that crashed back in the day, a Korean airliner that crashed in Guam many years ago. And I was part of the team that went, and we did search and recovery in the middle of a jungle for about a month. So my PTSD is related to that, but it does get, I do have to once in a while put myself into check and maybe even seek therapy because of life stressors, some of the anxiety that was related to that, I can feel those coming back up. So I did, the first time I went and I tried to see a therapist around it, he literally said, "Oh, maybe you should go to the VA." I'm like, well, I'm already in your office. Yes. I made an appointment a month ago. I'm in your office. We're talking. Yes. This is not combat related. This is not anything like that. I'm like,
and do you know how hard I had to work to get here and say it out loud?
It's a traumatic experience I had to deal with. And now you're telling me I should go to the VA. And I'm like, let's just talk. Can we just talk about this? And so, yeah, so I'm relating my own experiences with what you're saying, but it's true. It is like when people don't know what to do with you or don't feel comfortable. They're like, oh, maybe this other person can help. I'm like, do you know what I had to go through to get to this point that I'm talking to you? I'm sharing this. Very uncomfortable for me. This is not so. Yeah, I agree. I think
so painful.
We do need to definitely do a better job.
Yeah.
How is the mental health system in Canada? Because I can tell you in the U.S. we don't do a great job at it.
So I'd say it's twofold. It's if you have private coverage. So in Canada, in Ontario, anyways, psychotherapy isn't covered under our Ontario health insurance. So that's something that you have to not long term. It's not covered. I'll just qualify that a little bit. If you have private coverage, you can go and get that yourself. So through your own insurance benefits through work. If you are linked to a family doctor who has access to mental health support, they can refer you, but it's going to take a long time.
Wow. To
get in. So it's a system of, if you're in the system, it works really well. But if you're not in the system, it doesn't work well at all. Wow. And it depends on where you are in the country. If you're in northern parts of the country, it's very difficult to get sustained, adequate, culturally sensitive programming and mental health support. If you live in Toronto or Vancouver, you've got your choice, all kinds of choices, right? If you happen to speak, if you happen to come from cultures where maybe you would want to have your own language heard and spoken to you, that puts an even bigger barrier in between. So we're doing it, but not quickly enough. And it's great for some people, but not great for others, which I would say there's a lot of education and support, education and understanding and stigma reduction, but not a lot of backup for how, once you realize, oh, hey, guess what? I need help. How do I get it? It's very hit and miss depending on where you're from. Yeah. And it's like that. Is it like that, or is it?
In the U.S.,
in the U.S.,
I think in the U.S., I think what access is definitely an issue. There's just aren't enough providers, and then a lot of providers specialize. So, for example, not a lot of providers out there that work with children. So that becomes problematic. And a lot of it has to do with reimbursements and insurance and things like that. A lot of insurance companies put like a limit of how many sessions you're able to go to, like, okay, you have 10 sessions for the year, so you better get better by then, or I don't know. So I don't know how that quite works, because usually you go through 10 sessions within a few months, because if it's within like 2 or 3 months, and if you're not better, then you're asked to come out of pocket. Then there's the co-pays and things like that. So there's a lot of barriers. And then from an institutional perspective, the U.S. closed down a lot of hospitals for voluntary, not for mandatory admissions for mental health issues is a problem. We do have, not enough beds for the number of people that need to be institutionalized, even from like a 72-hour hold or anything like that. Even a 24-hour hold becomes problematic. But anything long term, we definitely don't have the proper access, and that leads to a lot of things like homelessness, loss of job, it's just it's definitely a problem in the U.S. and I don't see it getting better anytime soon.
No, and same here. Not enough beds, not enough long-term support, treatment centers, addiction treatment centers, and things like that. Same issue. And there's a lot of walking wounded folks.
Yeah.
Yes. That could be seen. The one bright light, at least from my perspective as a nurse, is that the College of Nurses of Ontario fought and the RNAO fought really hard to keep psychotherapy as a nursing practice so that we didn't need a physician's order to be able to initiate and continue with the practice of psychotherapy. So
again, amazing.
Yes, which is great, and that's just not. I don't think there's not enough nurses yet in private practice, but I'm hoping that it's going to get there, because that would increase more access for lots of different folks.
And I think that's the biggest issue is access. Like by the time you get into like, we had I've known people in the past who've tried to seek assistance. They didn't qualify for I want to say like a mandatory admission, right? They wanted to like self-admit because they knew they are not getting better and they just needed that inpatient style care. Yes. And like I think California has maybe one, maybe two in in the whole state that are voluntary, and obviously the beds are not that many. So most of the facilities I think in the US are involuntary admissions, but by then it's late. Yes. In the game when people know they're going down a path that is going to lead to an involuntary admission. If we can hit that like early on, would be that much better. So I think that's one of the things that's it's unfortunate. It's unfortunate.
Oh, incredibly unfortunate. Missing a huge ability to activate nursing roles,
right?
In being able to support those kinds of initiatives to get broader and bigger and more sustainable. Is somebody playing the flute?
Yes, that's my daughter in the background. I just muted myself.
It's beautiful. It's great. It's a live recording, and it's COVID.
It's COVID. This is COVID podcast.
100%. Yeah. One of my nursing colleagues said, "It's COVID, man. Like, what are we supposed to do? Just do what we need to do."
And I never know when it's going to happen, so I can't schedule around it. So it just happens.
Right.
It's her class. So I can't do it. Yeah, but yes, I agree. So before we finish off our talk, and it's been great. Anything you want to add? I know there's courses that you offer through your site. Anything else you want to cover with us?
Sure. So if your listeners or anybody really is interested in learning a little bit more about love-led leadership, they can certainly check out my website. It's sheenahoward.com. And if you're interested in the courses, there's one on the only one in the world in love-led leadership. And then there's also a companion course called the Be Love-Led Blueprint course. And that one, they're perfect to get together because you do the theory and the practice, but then also get the hands-on tools to be able to negotiate and how to utilize love-led leadership in your own personal leadership, but also in your professional leadership. There's also the free Facebook group, the Love-Led Leadership Facebook group, which is open. And then we also have the Love-Led Leadership Lab, which is a private members-only group where we dig really deep into love-led leadership. We do coaching. I do coach and mentorship with the group every other week, doing live coaching calls, and we get to get our hands engaged in practicing some love-led leadership practices, for lack of a better word. And people have found that really great because they're able to come with their leadership wins, their leadership challenges, and have a love-led lens and eyes on that as a collective whole, and be able to have access to a coach twice a month. So there's also that. And that is that website is portal.sheenahoward.com. So that's where you can access the courses.
And that is a link I have on my website. So if anybody's interested, they can just definitely connect with you along with your social media links. That is also available on our website.
Yes. Thank you, Ali.
Sheena, thank you so much.
Thank you so much.
I greatly appreciate you being on the show. Again, first episode of season 2. Loved our conversation, and thank you for sharing your experience. And I learned a lot. I definitely learned a lot.
Great. Thank you so much. And a big shout out to your students.
Thank you.
They've gotten to the end of this hour. I'm excited to hear their feedback and their assignments too. So
Yeah. Like
Mhm.
like I mentioned, I use some of these podcasts, and I think it's important for our students to, or actually for nursing period, to hear from the different individuals like yourselves who are doing incredible work, and get a better understanding of what nursing is about, and now internationally. I
Yeah.
think you're my first international
All
guest.
right.
Also, wow, so many firsts.
Yeah. Woohoo. Yay, yay, international guests.
Yes,
Sometimes we don't feel that international being,
right.
what is it that the Raptors saying is north above everything? We don't feel
Definitely,
that. We don't feel
definitely.
that international, but I suppose we are. Thank you for
Yes,
having me.
yes.
It's been a
Thank,
delight. Appreciate it.
yes, thank you so much.
Mhm.
You have been listening to my incredible guest, Sheena Howard, and with me on the RN Mentor podcast. Have a great rest of your week, and I look forward to connecting with you again next time. Thank you so much, and have a great one. You've been listening to the RN Mentor with your host, Ali Tayeb. Please don't forget to visit www.alirtayeb.com. That's www.alirtayeb.com for podcast notes and resources. And don't forget to subscribe. Until next time, I wish you fair winds and following seas.